So we're currently busy working away on all these service streams, but in the near future, you'll see, I would expect in mid-June, if not early June, you'll see an activity-based funding system from IHPA that will define a national efficient price and classification for these services. We've been told numerous times that the outpatient service data is not good enough, and we probably see some merit in that argument, but on the other hand, there are some transitionary provisions that protect jurisdictions. I'll talk about those in a second. And in a transitionary environment, we think that we should use the outpatient data that we've got and that we should set outpatient weights and we should run with outpatient activity-based funding. We would expect to see a very significant improvement in data in the coming years. I'll describe how we're going to do that in a bit later on in the presentation. We also will define adjustments to the efficient price. So we will define, in our coming policy statement, we'll define what we've identified so far as 3 adjustments. One is for Indigenous patients, and we're in debate with the jurisdictions right now as to quantum. But there is statistically a very definite difference between indigeneity, Indigenous status of patients and their costs. So for equivalent classifications, there is a significant difference between Indigenous people and non-Indigenous people. And that's recognised in our pricing system as a loading for Indigenous patients. Unfortunately for New South Wales, there's not a lot of gain in the next loading, which is remote residents. In fact, it's outer regional, remote and very remote residents, according to the Australian government, Australian geographic classification system. We've found that people who live in outer regional, remote or very remote Australia do have a definite cost differential to those who live elsewhere in Australia, and we'll be recognising remote residents with a loading in our pricing regime. So that means if you live in remote Australia and you're cared for in Sydney or Perth, it doesn't matter where you're cared for, you'll still receive the loading, or at least the hospital will receive, a local hospital network will receive a loading for your care. No matter where it's provided, it's based on your residence. We've also found across the country, interestingly, every jurisdiction that is implementing an ABF program has struggled with their specialist paediatric hospitals and what to do about them. It's interesting, across the nation, there is a definite difference in some DRGs between specialist paediatric hospitals and general hospitals that provide paediatric care. Statistically different cost differential, which we'll recognise in terms of a loading, but it'll only be for some DRGs, and we'll publish which DRGs, obviously. In some DRGs, it's actually negative. Some DRGs, specialist paediatric hospitals, provide care at a lower cost rate than in general hospitals, but there are some, particularly associated with paediatric ICU care, where that higher end of paediatric intensive care adds a very significant cost differential to some DRGs. So that cost differential, positive or negative, for specialist paediatric hospitals will be recognised in our pricing regime by certain DRGs. Overall, it's a positive loading across the hospital as a whole. We'll be publishing our specifications in our determination. They'll largely be a reference to existing specifications, so there won't be anything revelatory in that announcement. We'll also be publishing our block funding criteria. I've already given away our threshold for rural hospitals. It's not a secret, we've been discussing it publicly for months. We also have the terrible, burdensome duty. I spent all last night wrestling with a document which I've been wrestling with for 6 months, on defining what is a public hospital service. It's a uniquely Australian issue. When we talk to the NHS pricing people, and even some, we've made some early contacts in US Medicare, and we tell them that we have to define what a public hospital system is. What a lame use of your time. Because they work in a single funder system, they don't need to define the hospital boundary. They've got a single funder across primary and secondary and tertiary care. But in the Australian situation, we have to define what is a public hospital system service. We have to define what is a public hospital service for the purposes of this funding agreement. So we've had a bash at that. We've given it our best try with consultation with clinicians and jurisdictions, and we've provided a draft description of a public hospital service to all the jurisdictions, none of which are happy. But we now are in the process of finalising that in the coming days. And your Minister and DG have been very helpful in pointing out some key issues for IHPA to consider, particularly in regards to forensic mental health and other services that are often not paid due recognition when you get down to an exercise like this. So we will publish in the near future a description of what is a public hospital service in Australia. It won't be campus-based, so services that reach out into the community will be included, and it won't be restricted to provider. There are some services in this state and others that are provided by private organisations on behalf of public hospitals. So it'll be service-based and it'll be related to a set of principles which we'll publish. The reason that's important is that services that are defined as public hospital services qualify for Commonwealth funding, and services that don't qualify for Commonwealth funding under this agreement. There are other agreements, but not this agreement. And we'll also publish our dispute determinations and assessments when we get them.